Okay, so we seem to have plateaued a little with those coming in, so we'll make a start. Thank you to those that have arrived for 10:30 start. So apologies, there was a little hiatus there. Hopefully you've got a drink and you're enjoying the sunshine next to a window this morning. So welcome to this webinar that is hosted today by the MHRA, and the subject matter is clarifying digital mental health technologies, or DMHTs, as for qualification as software as a medical device. So we'd just like to start with some brief introductions. My name is Holly Cool. I'm the Senior Manager for Digital Mental Health at the MHRA, and I will be chairing this session today. And I'd like to introduce you to two colleagues who are part of this project team, and I'll give you a little bit more of an overview about the project in a second. So if I could introduce my colleague Francesca.
Hello, hopefully you can hear me, just because I have had a couple of IT problems, but nice to meet you all. My name's Francesca and I work with Holly on this project.
Thanks, Frankie. Francesca, Frankie, we'll go either or. And also Gareth Hopkin.
Hi, all. Yeah, I'm Gareth, and I'm a scientific advisor in the Science Policy and Research team at NICE, and I'm leading on the project from the NICE perspective. Perfect.
Thanks so much, both of you. So today's session, as I've already mentioned, is about digital mental health technologies that qualify as a software as a medical device. And the reason that we're presenting this information to you today is that we have previously engaged with yourselves to give you a little bit of an idea of the work that we're undertaking, which is funded by Wellcome. And it's a 3-year project that we are undertaking to try and provide a little bit more clarity around products that have been historically quite difficult to understand our guidance, our current guidance documents for. So we're hoping that this session will help give a little bit more clarity to the qualification process for those products. So we'll go into a bit more detail as part of this webinar. We are going to record this session, so recording is in process, and hopefully in a few weeks' time we'll be able to provide you with this recording for to enable you to come back and have a look at some of these slides. There will be a Q&A session at the end, which won't be recorded. We are happy to take questions, but we do ask that they are kept as closely as possible to the content of this particular presentation as possible. We are still in a period of some communications restrictions given the election that has taken place. So please do bear with us whilst we try and make sure that we can provide as full answers as possible. However, if you find that your question has not been answered, or you're feeling as though we have not been able to provide any responses as sufficiently as you would have liked, then you may well need to contact us at the software team, and we'll provide that email address at the end. But do bear with us. We will try and answer as many questions as we can, or point to some helpful documentation for you that's already published on our website where possible. If we don't have lots of questions at the end, or if we skip through the presentation quicker than expected, then we will close the session before 12 o'clock. So hopefully we'll be able to get some time back. But just to let you know that it's purely just to make sure that we've got plenty of time to allow you to ask questions at the end. Okay, so without any further ado, we can get started. So we're just going to outline the agenda then and the webinar objectives for today. So the first is that we will be updating on the progress of the Wellcome Trust funded project, as I've already alluded to. The second is to share the MHRA's approach to clarifying DMHT qualification as a SAMD, and we'll give you an overview of the current guidance. The background approach and examples to clarify medical purpose, the background approach and examples to clarify functionality, and also feedback from the project's working group. And the final part of today's session will be an opportunity for you, as I've already mentioned, as subject matter experts, to provide feedback and also ask questions via Slido, for which you should have the event code available already. So do feel free to start submitting questions through there, and we have a couple of colleagues who are helping to moderate those questions for us. So we will be able to work towards those at the end. So the main kind of questions around the areas, sorry, could we go back to the previous slide? Sorry. So we would like to essentially ask yourselves whether you think this proposal makes sense and will help, particularly as people working in the fields, maybe developing content, developing apps and websites, or having already started research to look towards developing digital mental health technology. Do you think that there are any aspects that need to be clearer? Do you think that we've missed anything significant in our proposal? And other than guidance and an inquiry form, what methods do you think we should use to disseminate this information to wider stakeholder groups? So just bearing those questions in mind towards the end in terms of your feedback would be incredibly helpful. Apologies, next slide then, please. So just to outline a little bit more about the Wellcome Trust project key outputs. So we did allude to this when I think we spoke to you previously last year, but essentially this project will look at the key stages of the product lifecycle over the course of 3 years and provide clarity for those digital mental health technologies that qualify as software as a medical device over each of those stages. So as you can see here in the green column, we have the key stage for each of those product lifecycle processes, and sorry, that's summarised, I guess, in the pink as well. So we've got some key defining areas in those stage cells of green on the left, product lifecycle summarised in the pink in the middle, and then the project outputs that align with each of those life cycle stages are to the right. So we have undertaken quite significant ecosystem mapping and stakeholder engagement, and we are now looking towards the third cells down and onwards, so around the guidance for qualification, and then moving towards some other outputs as we progress towards the project. So you get an idea as to some of the proposed outputs that we will like to perhaps engage with you around in future as well. Next slide, please. So the challenge and goal that we have in particular with this piece of work and this project is that many digital mental health technologies, as you are probably aware, do fall into a grey area for qualification with the current available guidance. Developers are often quite unsure and have difficulties with product development planning, and obviously this has quite a significant impact on funding applications that may be taking place, and that really it's about building in the regulatory awareness really early into these processes, so that there's a really clear awareness of what a product might look like if it is starting to have features of a medical device, and how that might have impacts on funding and also subsequent regulatory requirements that you would need to be cognizant of. So the MHRA do receive quite a large number of inquiries around these products, and it does take considerable resource to come to a consensus around whether they do or don't qualify as medical devices. And healthcare professionals, patients and the public rarely understand why some digital mental health technologies are and others aren't software as a medical device. And this has implication on choosing good quality, appropriate products. So our goal is to provide further clarity around DMHT qualification as software as a medical device for all stakeholders in different formats that are appropriate to the information that's required for those particular needs and wants. And then also this will help reduce time spent on qualification issues, help all of those involved understand the DMHT qualification, and that will consequently help with regulation, commissioning and the safe use of digital mental health technologies as a whole. Next slide then, please. So at this point, I'd like to hand over to Frankie, and she will take you through the next slides.
Thanks very much, Holly. Okay, so as Holly mentioned, we'll begin with a few slides just giving an overview of currently what the legal text and what guidance document there is already, and then hopefully we'll split up the rest of the presentation into trying to clarify the medical purpose aspect and then the functionality aspect. So this slide here is just detailing what is the legal text for the definition of a medical device in the context of software as a medical device. So in the black is what's currently the text for the EU MDD, and in the blue is the text for the EU MDR, as in the UK we're still accepting CE marks at the moment. The things to mention here are the qualification as to whether a product qualifies as a medical device is very much dependent on what the developer, the manufacturer defines in their intended purpose, what they put as their claims, and what's on their promotional materials, such in instructions for use and on the website. And that the following medical purpose are considered. So whether it's diagnosing, preventing, monitoring, or treatment for a disease, whether it's diagnosing, monitoring, treatment for an injury or disability, whether there's an investigation, replacement or modification of the anatomy or physiological or pathological processes or state, a control or support or conception, and whether it's providing information by means of in vitro examination of specimens derived from the human body, including organ, blood and tissue donations. So we could move to the next slide, please. So this slide here is trying to then show what is in the guidance documents at the moment. So the MedDev is guidance documents for the EU MDD. And as you can see from in figure 1 of that guidance document, step 3 points to this question on functionality. So is the software performing an action on data different from storage, archival, communication, or simple search? And then step 4 and 5 point to this medical purpose aspect. So is the action for the benefit of individual patients, and is the product fulfilling the definition of a medical device? On the right here is a similar flow chart, which is in the MDCG guidance, which are the guidance documents for the EU MDR. And similarly, the flow chart shows a functionality aspect, which is related to what action is the software performing on data, and then this medical purpose aspect. We could move to the next slide, please. So the next couple of slides just detail that similarly our MHRA guidance points to these two aspects. So a software product both needs to have a medical purpose, as shown in the green boxes on the left, and also it has this functionality aspect. So we've tried to show that just with the circles. So there's an example that if a product is only storing or transmitting medical data without change, then that wouldn't be considered to be enough functionality. Also, if the software is only providing reference material or it's only a database without any changes to the actual data, then these wouldn't be considered to have enough functionality to be considered software as a medical device. If we could move to the next slide, please. And this is just one of the appendix on the MHRA guidance. So it's pointing towards one of the sort of exemptions, which is if there is a calculation as part of the software product and there is a medical purpose, but the calculation would be considered to be simple and easily verifiable, then it wouldn't be considered to be software as a medical device. As it says at the bottom here of this guidance, this needs to take into consideration a typical user's knowledge and skills as to whether that and their typical use environment as to whether it be considered simple and easily verifiable for that particular user in that particular environment, and also that for a developer to be able to use this exemption, they need to have evidence to show that it is simple and easily verifiable, and the easiest way to do that is via sort of user studies to show that a typical user would be able to identify if a software product gave an incorrect result. They'd be able to notice this before there was any clinical impact. If we could go to the next slide, please. So as I said, the next couple of slides now are looking at the medical purpose aspect and why, a little bit of background as to why that's particularly tricky in the mental health area, and what we're proposing to try and make that hopefully a little bit more clearer. And then we've got some examples to hopefully bring that to life. So in terms of the medical purpose, so the MHRA often look at the WHO ICD-11 categories to give us sort of an idea of what is generally considered to be a disease or a clinical condition in the current state of, in the current time. So looking at WHO ICD-11 at the moment, there is a category on mental, behavioural or neurodevelopmental disorders, which categorises conditions based on symptoms. So these and other similar mental health taxonomies have been long established, have a global reach and significantly influence the way in which mental ill health is understood, assessed and managed. So they're really useful for us. I should also note that there's nothing in the legal text or guidance that says we need to follow exactly WHO ICD-11. It's just one way that we try and we look at as to what it's established. The problem or the challenge, let's say, in the mental health area is that there are a couple of challenges with using this sort of strict categorization, which I'm sure many of you on the call know even better than I do. But so for mental health in particular, some of the symptoms can fluctuate along a continuous dimension rapidly. So that means they can move in and out of these established conditions quite quickly. That can make it hard for determining whether a product is used for symptoms before sort of subclinically or for more clinically. There's also high comorbidity and poor discrimination between supposedly different disorders. There's also significant variation within diagnoses. And also, maybe most importantly, research and clinical practice often assess and target transdiagnostic symptoms such as low mood, poor sleep, anxiety, paranoia, and the impact on functioning. And then lastly, an important point to make is some patient service users prefer or are reluctant to use a label for a mental health condition as well, which can make it tricky in terms of advertisement for mental health products. So if we move to the next slide, please. So in terms of our approach for trying to hopefully clarify this medical purpose challenges, so we're really hoping to lean on guidance that's already out there. So there's an MHRA guidance on crafting an intended purpose, and it's really asking developers to be very clear for what their intended purpose is. In particular, we'll ask developers to be really clear if a software is targeting a symptom, for the developer to make it clear whether that is targeting the symptom at levels considered subclinical, so well-being type products, or whether it's targeting symptoms as part of one or many clinical conditions, or both, of course. Another point that we really would like to make clear is we see a lot of products that are maybe targeting more subclinical well-being, but they are for patients who have another diagnosed condition. So for example, epilepsy. So we want to make clear that in those cases, even though it could be argued that the product is targeting, it's a more well-being product, because it has this this specific focus for those who are who do have another medical condition, that we would consider that to be a medical purpose. We also think it'd be really useful for us to provide further guidance on the definitions of prevention, diagnosis, prognosis, prediction, monitoring, treatment, aidation and compensation. In particular, that definition of diagnosis, where there's often a lot of discussion about what exactly that means, whether that's a very narrow interpretation of the sort of the final diagnosis where it's definite, or how it's really considered in the regulatory world of this sort of this broad process where there's many steps to a diagnosis, and aiding to diagnosis is also considered a medical purpose. We also think it'd be useful to provide further guidance on the definitions of disease, injury and disability. So these words are seem particularly tricky for mental health, as we don't really talk about disease or injury as much in this area. So trying, although that's the legal text, if our guidance can give that broader scope of that includes clinical conditions, and then, as I said, if it's pointing towards a symptom, for it to be linked to the clinical condition. So at the moment, our MHRA guidance doesn't have any digital mental health technologies examples. So one of the main outputs of this project is for us to provide those examples, which hopefully will be able to clarify the guidance better. And we are also looking into providing a form which will help developers be able to categorize their devices. So a way of communicating what their product is doing and how to formulate their intended purpose, which that would then go on to help with the determining whether it's qualifying for as software as a medical device, with the hope that that could both help with a way of communicating the product, but also may actually help a developer come to a determination themselves. If we could move to the next slide, please. So this slide just gives some examples of that subclinical well-being versus clinical mental health point that I've made here. So the first example is potentially a way of a wording when a product is only for well-being, so it wouldn't have a medical purpose. So this example states that the product supports treatment of poor sleep. This product is only for well-being, and when poor sleep would be considered at subclinical levels rather than clinical levels as part of a diagnosable mental health condition. It does not have evidence to show that it helps if you have poor sleep at clinical levels or part of a diagnosable mental health condition, and it is not regulated as a medical device. So this sort of wording would make it really clear to all stakeholders. So most importantly, those who are trying to choose a product, whether it is suitable for them, either a patient, the public, or a healthcare professional. It also has it will be helpful for those who are commissioning products, and of course, in terms of the regulation, if it will be really clear what evidence is required for this product, because the intended purpose statement is clear. In the second example here, it's giving some words to how you could describe when a product is both for well-being and has a medical purpose. So support the treatment of poor sleep, which may be at subclinical levels or clinical levels as part of a diagnosable mental health condition such as insomnia, depression, and anxiety. If we go to the next slide, there is now just an example of some words that could be used for that situation where a product is targeting more subclinical well-being symptoms, but there is another medical condition involved. So the product could be supporting well-being and anxiety symptoms for those with epilepsy. This digital mental health technology is different from one that supports well-being and anxiety at subclinical level for the general population, as it is specific for those with epilepsy, therefore has a medical purpose and is regulated as a medical device. Again, nice and clear that it has a medical purpose and therefore could be considered software as a medical device. If we could go to the next slide, please. So the next few slides now are looking at this functionality aspect. So for many digital mental health technologies, they do have a clear medical purpose and medical claims. So for example, treatment of a mental health condition, as we've gone through. But we do see a large number of products which have very limited functionality. So as the slide showed at the first there, at the beginning, there's the EU guidance, which is very much clear that there is not just a medical purpose question, but there's also this functionality aspect as to whether a product is doing more than storing, archiving, or communicating data. And then also the MHRA guidance also has this aspect in as well. So based on this EU guidance and MHRA guidance, which is already around for general software as a medical device, the MHRA have internally agreed a framework to try and assess whether a digital mental health technology would be considered to have low functionality and therefore not be considered software as a medical device, or high functionality and therefore software as a medical device. So if we go to the next slide, and it gives a little bit more detail about the approach here. So what we're suggesting is that we'll continue to evaluate both medical purpose and functionality for software as a medical device. So most importantly, this means that not all software that has a medical purpose will be considered software as a medical device. And then most importantly, we'll hope to try and provide further guidance on this agreed framework. So what would be considered low functionality and what would be considered high functionality. And again, similar to the medical purpose side, we're having a look at whether we can provide a form which would be a way of developers to be able to easily communicate what their product does, what the functionalities are, and how they have determined whether that would be that would make it software as a medical device or not software as a medical device. So if we go to the next slide, please. So this hopefully speaks to these points of trying to give a bit more clarity about low functionality and high functionality. So in terms of describing low functionality, which is easily verified, So as I've already mentioned, the EU guidance already points to whether the software is performing an action on data such as storage and communication. So of course we'd keep this, and we're thinking of adding in this phrase of whether the software is only performing an action, an action of simple user instruction. So what's meant by that is if the only thing that the software is doing, the sort of the calculation behind it, is based on the input being a user pressing on particular buttons and that making a certain output. So for example, a user pressing on a module for anxiety, and then that module is shown to the user, that would be considered simple user instruction. And we think that would be that would fall as a low functionality action in a similar way to storage and communication. We're also trying to describe this low functionality as when the inputs do not affect the output. So again, if the software only has fixed content and it's not personalized or interactive, then this would be considered to be a low functionality, which is easily verifiable. Another way is seeing how similar or how different it is to an online book or journal. So if it is very similar to an online book and the only sort of functionality that's happening is a person choosing modules in the same way as a person could choose a chapter of a book to read, then this would be considered low functionality and not software as a medical device. Most importantly is this next line, that it needs to be, the software needs to be presented in a way where a user can easily understand the output and identify any output errors before any clinical impact. So some examples of functionalities which could fall under this are a digital diary, and that's if the digital diary didn't have any sort of calculation or algorithms in the background. So it literally was just a user inputting information and the software was just storing that information, and they could review it. Also simple questionnaires and quizzes, again, depending exactly how it's presented, but if it's presented in a way where a user could understand the result. So for example, they input what they think their answer is, and the software would say, that's correct, you can find further information at yada yada yada, or that's incorrect, you'll find the right answer in this module, then this could be considered to be low functionality and easily verifiable. Again, for any sort of questionnaires such as PHQ-9, if it's presented in a way where a typical user could be able to work out or look back on their raw data there and work out how they've got a result, then if it's presented in this way, it could be considered to be simple and easily verifiable. As I've mentioned, the fixed modules, if there's no further functionality going on around it other than these fixed modules, this could be considered to fall as this low functionality. And an e-coach or therapist, if there's just a communication that's going on between either two patients or a patient or a healthcare professional, and there's the software itself is not changing that information in any way, or there's no alarm or triaging or prioritization that's going on. If it's just simply a communication tool, then it wouldn't be, then it would fall as this low functionality aspect. So if we could move to the next slide, please. So this slide here just gives some examples to what would be considered high functionality. So the obvious thing is it's software that's performing more action on data more than storage, communication, and as a result of simple user instruction. So in these cases, the inputs do affect the output. So the software could be described as personalized and interactive. And then a typical user may be unlikely to identify software error before clinical impact. So some examples for this is, so if a software has an alarm or flags priority cases for a healthcare professional to review, this would be considered to be high functionality. If there's conversational AI that allows users to input free text messages, which presents clinical or personal challenges, and the AI points the user to it in the direction of suitable module or acts as a therapist itself. If the software includes a game that helps users learn skills and manage their mental health, this would be considered high functionality. VR type of products where the therapist personalizes the environment based on the patient or the user needs, and the patient or the user interacts with that environment would be considered high functionality. And then, of course, those software products which have complex algorithms or use AI to assess or triage mental health conditions would be considered to be high functionality. We could move to the next slide, please. So this just gives a summary of what I've been saying, really. So the first point to make is the intended purpose and the claims is based on what the developer has communicated about the product in terms of their labelling, instructions for use, and any promotional materials. It's also important to make that there's a precedent in the UK that there is also a look at how a typical user would be actually using the product. So what that means is if a developer is saying it's just a wellbeing product, but they are aware that that product is being used in a medical purpose way, there is the responsibility of the developer to ensure that there's consistency with both the intended purpose and how the product is actually being used. So in that circumstance, one of the choices they could make would be to change the intended purpose to ensure that it is actually including a medical purpose, ensure that it has the right evidence and is correctly regulated in that way. And then the two-step process that we've described is this medical purpose aspect. So does it aid diagnosis, prevention, monitoring, prediction, and treatment? Does it target symptoms, conditions at levels considered subclinical well-being or clinical? And then looking at this functionality aspect. So is it performing an action on data different from storage, communication, or simple search? Is there evidence that the function is simple and easily verified? So at this point, I think I will hand back over to Holly for the last few slides.
Thank you, Frankie. If we'd like to go to the next slide then. So as you were informed at the beginning, we do have a project working group, and they have already helped us develop this content to get us to this stage. So hopefully we preempted some of the questions that you might have as a result of this presentation, and want to take you through some of the questions that the working group presented to us and some of our responses as well. So the first question was that asking developers to state that the product is targeting subclinical or clinical levels of symptoms and identifying conditions that could be unhelpful. Because there's a move generally towards a more needs-based care. So we understand that this may be a concern around it potentially being an unhelpful ask, but if we don't ask for it, we then continue to have digital mental health technologies where it's really unclear whether it's intended for those that are experiencing symptoms at a subclinical level, or if they are kind of a diagnosable condition that's actually going to be of benefit to them. So it's actually helpful to encourage a developer to be able to really clearly define what the intended use for these products are. So the other key thing is it's around the evidence as well. So being able to define the intended use based on whether it's targeting subclinical or clinical symptoms, then enables us to see, well, what evidence do you have to substantiate that? So those experiencing mental health difficulties, symptoms of any spectrum deserve an evidence-based therapy, and therefore we believe that we should be asking these questions of developers to really clearly define what it is that their intended use for the products are. So the second question that came up was about more information on symptom versus condition and subclinical versus clinical, and lots of examples for different symptoms and conditions would be required, and we agree we will need guidance on developing this, in particular on the thresholds for subclinical and clinical, based on sort of standardized assessment measures or validation tools that are used in practice. So again, as part of our working group, we do have clinical experts as part of that, but we would also hope that we could perhaps reach out to stakeholders to help sense check some of those approaches as well. So we are aware that comes up as a frequent question with regards to how we define that. We're very aware of that, and we do need to seek more guidance on making sure that is clear. The third question was about being more prescriptive about the evidence that we need, so using a kind of a PCOS method here, and we absolutely agree. So asking for the clear intended purpose helps us understand the qualification and evidence requirements for these products, and similarly being prescriptive about evidence that that you need to substantiate those. So similar to question 1 there, but it helps clarify the intended purpose and the qualifications. So we'll be moving into sort of more on that in work package 3 to make that a bit clearer. Next slide, please. So again, a little bit more around the targeting of subclinical symptoms that could still be considered to be preventing mental health conditions and therefore have a medical purpose. So we do agree it can be helpful to clarify this in our guidance. But those digital mental health technologies that help symptoms at a subclinical level, and there are no claims that prevent a mental health condition, therefore are unlikely to have a medical purpose. But those DMHTs that help symptoms at a subclinical level and claims that it prevents a mental health condition are then likely to have a medical purpose and therefore then need to be backed up and substantiated by evidence to demonstrate that. So again, all comes back to this cycle of making sure that we have a really clear intended purpose, that what the claim that it's doing enables a user to be able to select an appropriate product so that they know that the evidence behind it supports that usage. Next slide, please. So some questions that arose around functionality. So the first was a concern that medical device regulations won't cover digital mental health technologies with medical purpose and low functionality. So therefore going through kind of our approach that Frankie's taken us through there. What about those that don't qualify? So what other assurances are there to safeguard the use of these? Well, there are actually plenty that are already in existence, but we do agree that this is a concern for stakeholders. So it's first, we need to put it into context, this is similar to a healthcare professional recommending a book or a lay user choosing a self-help book, for example, and not all software used in healthcare is software as a medical device. So it's not just this particular therapeutic area where this will be the case. So the risk of software error is low in those with low functionality. However, there does carry some risk of misinformation, but other insurances include, and this isn't an exhaustive list, these are kind of the areas that we've come into contact with mostly so far as part of the project. The Information Commissioner's Office, so the ICO, and GDPR. We've got the Advertising Standards Agency, various healthcare professional bodies, so the GMC, NMC and the HCPC, Care Quality Commission, and then the NHS DCB standards and the DTAC. So all of these have very specific role and apologies. I think, am I still in session? I don't know what happened.
We can hear you again now, Holly.
Thank you. I don't know what happened. I completely dropped out, I think. So apologies about that. We, again, as part of the project, want to give an idea about best practice guidance on digital mental health technologies that are not SAMD. Again, not usually something that the MHRA would do, but I think as part of this work, we're very aware of there being concern about those products that don't fall into qualifications. So we'll be able to provide a bit of a summary of kind of the other areas of regulation that we have just mentioned there. And then a second question that came up was about giving further clarity on transfer of data and what that means, because it could mean the GDPR, whereas actually in this context it means transfer to a healthcare professional. Again, we just need to be very clear in the guidance around what that actually means and who that's referring to. Next slide, please. And then some other considerations that came up as part of the working group discussions. So a consideration of a multi-modular or interconnected device and whether further details of that should be featured in guidance or in the forms that can be provided. And again, we agree that this clarity would be really helpful to include in guidance for software as a medical device, not just necessarily digital mental health technologies, because we are aware that it is actually quite common practice for a developer to have maybe multiple systems or multiple modules of a product, some of which may be medical devices, others may not, but being aware that some of those can be regulated as a full kind of system, but they can also be regulated individually depending on their functionality and medical purpose, as we've just outlined. So we want to make sure that that's really clear. Again, to make sure that products are not slipping through the net that potentially are medical devices and need a high level of regulation, but also not over-regulating those products that don't need to be regulated because they don't qualify. There was another question around the consideration of the rapid changing nature of software products and what best practice really should be, and what's realistic for developers to follow when expanding their intended purpose statements, and how this can be featured in guidance and forms. Again, we totally agree with this. So we hope to have more discussion on this particular topic in Work Package 3 around clinical evaluation. So specifically, really what is considered significant change, and making sure that that actually is relevant and proportionate to software as a medical device, and the rapid sort of changing nature, as we've already alluded to, of these products, but also making sure that we're being proportionate about how we look at that, and what evidence is required for any changes and expanding medical purpose or functionality. So we will be looking at that as well. And the next slide, please. I think that concludes all the questions that we have had through on the chat and on Slido. I'd like to really thank you for your attendance today. Thank you to all of those involved in organising this particular webinar, to Frankie, to Gareth as well, and to Zainab, who are in the background. So thank you all for your attention, and we hope to be in touch with you all throughout various stages of the project to keep you up to date with the work that we're undertaking. So thank you, enjoy the weather today, and hopefully we'll speak to you soon.